And welcome to our second panel discussion here at the Geneva Health Forum. I'm Sarah Chiarello and I'm hosting this morning session. What role can the vaccine play in eliminating malaria? The objectives of the sessions are to discuss the current state of malaria vaccines, their role in control and elimination, and the challenges of implementation. And to do so, I'm delighted to welcome our moderator for this session, Isa Ciglenecki. She has worked in Sub-Saharan Africa and now coordinates operational research for MSF, Operational Center in Geneva, focusing on epidemic control and new vaccine introduction. Welcome, Mrs. Ciglenecki. You can see here.
Thank you so much for the introduction, and many thanks for the invitation, and welcome to this discussion on the malaria vaccine. I think the previous session already stalled a bit our discussion. They were discussing a lot about the vaccine, but I think we'll try to dig more in details. So my name is Isa Ciglenecki. I'm a medical doctor and epidemiologist, and I have been working for MSF for the past 20 years. But the first time I worked in Sub-Saharan Africa was actually during my studies in the late 90s. I was in Zambia, and at that time for treatment of malaria we were still using chloroquine, and the mosquito nets were there as a physical barrier. No one was using insecticides yet to treat them properly. Many things have changed since then, and with the widespread use of ACTs, diagnostics, and universal distribution of long-lasting insecticide-treated nets, all this together contribute to halving malaria deaths since 2000. But then, unfortunately, since 2015, actually this progress has stalled. And in fact, in some of the high-burden countries, the number of malaria cases and deaths is increasing. So, on the other hand, I think for anyone working in malaria, having the malaria vaccine, this is really like a dream comes true, right? But the history of the vaccine development has been very long and very frustrating. There has been dozens, if not hundreds, of vaccine candidates that have been developed and failed in the process since the mid-last century. The parasites are very complex creatures to develop the vaccine against, and the development is challenging. Also, the story of the first malaria vaccine we have, the RTS S, has been long and not without bumps. It took 30 years to develop the vaccine, and then when it was finally regulatory approved in 2015, it still took almost 10 years until this year when the vaccines are actually being rolled out in the national vaccination programs. So today we have malaria vaccine, and we don't have one, we have two vaccines that are recommended for the WHO to use in the areas with moderate and high transmission. And even better, we have enough supply, so we don't have to worry anymore about the shortages of the vaccine. The manufacturing capacity is sufficient to cater to anyone that needs the vaccine. But yet, I think there is many questions that have been highlighted in the previous discussion. Can this vaccine that have very challenging implementation schedule and logistic be the tipping point in malaria control and help us reach malaria elimination goals? So I want to thank you and thank my panelists and invite them to discuss with me this topic. So I would first like to introduce Dr. Philippe Duneton, who is the Executive Director of UNITAID, to join me on the panel. Thank you very much. Dr. Kim Lindblad from PATH. She's the PMI's Insights Technical Director and Senior Technical Advisor at PATH. Thank you very much. Dr. Kwaku Asante, who's a public health physician and the Director of the Kintampo Health Research Center. Thank you for joining us. We have Aurelia Nguyen, who is the Chief Program Officer at Gavi. Thank you very much. And we have Dr. Michael Charles, who is the CEO of the Rollback Malaria Partnership to End Malaria. Thank you very much for joining us. So to start our discussions, I would like to ask each of the panelists to introduce the institution themselves a little bit better and the role in the malaria vaccine and how you see the role of malaria vaccine in the fight against malaria. Thank you.
Thank you. So I'm a medical doctor in infectious disease and public health. And actually, I was thinking this morning that the first time I've done, in French we call it, the frottis goutte épaisse, to detect malaria. It was a doctor, a colleague, older, a woman, who taught me to do that, but she was working on the malaria vaccine. It was 40 years ago. So, and it was, it's a long story, let's say. So, as you said, I think that for all of us who have been working in that area, vaccine is a dream. And we knew the challenge in front. UNITED is not really focused on vaccines. We are really focused on medicines and diagnostic and tools. So we have been working, for example, for a long time on the bed nets. We have, together with Global Fund, introduced the new bed nets. My colleague yesterday at the Global Fund said that we have, the Global Fund has bought 200 million of nets, and it's really relevant given the development of the resistance, of course, of the mosquito, but also we have the challenge of the resistance of the Plasmodium also. That's the reason why we are working on changing the type of drug to diversification, because so far we can see this. Coming back to the vaccine, we have been engaged with Gavi and the Global Fund to fund the phase 3-4 of the RTS S in 5 countries because of the challenges, and we were like, yes, we need to understand how, because, at the beginning there was this surmortality among girls that, for me, I'm an ex-regulator, that kind of thing. You don't like it to see. But it turns that, no, that signal was overturned, and there was the measurement of the efficacy. So we have really, I think that we did the right thing. The second part, if I have to say what we think, I will quote the Minister of Nigeria. He told me something, and I have his authorization. Mohamed Pate, everybody knows him. And he said there is a story about the guy who is a taxi man in New York. He has a crash accident, he died, went to heaven. At the same time, there was a priest in the church who died from a heart attack, he went to heaven. So Saint Pierre said, taxi man, yes, go there, it's heaven. And you see the priest say, no, you, the other side. And the priest was not happy with that, say, but what the hell is it? And Saint Pierre said, now we are enforcing management of performance. You have less people in your church, and this guy driving so fast in New York, all his clients were saying, oh my God, all the time. He was making the case that data are quite important. And I think it's where we are, I think. We all know, because the bar is high, elimination. The bar is high, but it has been done in a lot of countries already, even countries very close to my heart, and we see the elimination without the vaccine. Doesn't mean that we don't need a vaccine. But it has been done with different tools together. Different tools as a countermeasure, but also other tools like sanitation and other things that are not directly linked with, of course, the medical countermeasure. I think it's something that we need to have in mind. The second point is that we have 2 vaccines, but we know their challenges. I think the first RTS S, to be honest, the good thing is we need a first vaccine, and it will remain a first vaccine, but given the complication in terms of production in terms of adjuvant, in terms of price, the dose is around $10, if I'm correct. It's a challenge for implementation. Just you to have an example, because I was trained also as an epidemiologist, and I was told that the best thing to do with a figure is to compare to another figure. So we have invested a lot in seasonal chemoprophylaxis, now used in a lot of countries in the Sahel zone, but even in other zones. And when we started, it was 13,000 child. And we pushed the production of pediatric formulation and so on. And now, according to WHO, is 54 million of kids every year who benefit of that, with an impact on the diminution of case and mortality, but also diminution and transmission. So when I see the recommendation and say, oh, but in that zone, and the cost is $4 for all the prevention for a year, for the month for the rainy season. So $10 the dose for the vaccine that has to be used 4 times. Well, it's part of the challenge. The new one, R21, it's a pity because when we start to see the first data, we were like in terms of efficacy, it's dramatically different. It turns it's not that different, but at least it's less expensive because it's between $2 and $4 a dose. Even if the way to use it is not that easy. But it's 4 times or at least twice or 4 times the price of this intervention. So basically, and I think that we will all discuss that, to do the SMC plus the vaccine, what is the rationale? You know, and I think that the other point is that when we talk about vaccines, we have a mental representation of, I don't know, the vaccine of measles, tetanus, or things like that. I think the reality, we have a different type of vaccines. If you look at the vaccine for COVID-19, for example, there was no much impact on the transmission, and he has a therapeutic effect because he has a big impact in the reduction of mortality among the people with severe cases. So in terms of efficacy, well, comparaison n'est pas raison, but it seems that the malaria vaccine is a little bit in that kind of category of vaccine because the impact is on the mortality. Sometimes it's quite difficult, it seems, to link that to the specific mortality of malaria, according to the data. So there are a lot of challenges. So I will conclude to say, and it has to be discussed, I look to the recommendation of WHO for sure. The first, there is a strong appetite from countries to use these vaccines, but there is at the same time a strong competition on the mix of tools that we need to use to fight malaria. And I was with Charles in Yaoundé on the malaria conference with the 10 countries most affected in Africa. 90% of the deaths in the world by malaria are in these 10 countries. So frankly, there is something to be done. And so the question is really to say, yes, we have in the pipe some other tools to control the malaria, not alternative to the bed nets, unfortunately, so far. But I think that the way we see the vaccine malaria at this stage is part of this tool, even if the difficult job, really difficult, I think, for countries, is to make the right mix. Just a caution, and we need also to say that it's the challenge is the finance, because we have collectively half of the money we need to fight malaria. So we are thinking of that under that kind of constraint. That's a reality. That's a reality that the Mediterranean countries are facing. So I think that tools, how we deploy this, is still a challenge. But the truth is that maybe we can have surprises. So, I mean, the introduction of new tools needs to be monitored and continues. That's the priest and, performance driven. Because sometimes you have bad surprises, sometimes good surprises. So who knows? It will be, and what I can say, for elimination, for the high transmission, we may need another tool, a better vaccine. But it's for sure a contribution. Thank you.
Thank you so much, Philippe. I think this is really about, we have to use the tools we have, but we should not stop here. We have to think in future. Up to you, Kim. Thank you.
Thanks, Isa, and thanks so much to the Geneva Health Forum for inviting me and PATH to be present at this forum. So I am a field malaria epidemiologist. I started my work in Uganda back in the early 90s when we also only had blood slides and we were treating with sulfadoxine pyrimethamine at that time, and we didn't have bed nets. I got involved in one of the last of the big bed net trials, and at that time I think it was quite a failure of my imagination to think that we were ever going to be able to scale bed nets up. But clearly the past 30 years have proven me completely wrong, and bed nets are available widely throughout malaria-affected regions in sub-Saharan Africa, and they've been incredibly important in having the impact on malaria mortality and morbidity that we've seen since the early 2000s. We're in a much different place than we were 30 years ago, and in part now because we have this new tool that's finally come about after a really long period of gestation. The RTS S vaccine was first developed in 1987, so it has been a really long time. PATH has been involved for about 20 years in the development of the vaccine. PATH started out as the Program for Appropriate Technology in Health, and it was very health technology focused. It has a lot of experience bringing vaccines through clinical trials and to production, and then working on market shaping after that to make sure the vaccines are available and taken up where they're needed. And they got involved in conducting phase 2 and phase 3 trials for the RTS S vaccine, worked with people like KP in the phase 3 trials that were conducted in 7 countries in sub-Saharan Africa between 2009 and 2014. I think we all were not surprised, knowing what we know about the biology of malaria, that we didn't see a huge impact, but we were very pleased to see the impact that we did find. And there were several concerns about the vaccine at that time that led WHO to recommend a pilot implementation program before the vaccine was recommended, and I'm sure we'll hear more about the successes of that implementation program. But we're now in a point where we have not just one, but these 2 vaccines, and we're really on the precipice of seeing what impact they're going to have. I think we've already had a few surprises out of the MVIP, 13% reduction in all-cause mortality, which is really substantial. And I think that maybe we're going to look back on this point 10 or 15 years from now and see that it was a time at which we start to bend the mortality curve. And that would be really, really welcome, because we know that mortality and morbidity have stagnated since around 2015. Lots of reasons for that, and some of those reasons are that we're still not implementing our existing tools as well as we should be. We know there are huge gaps when it comes to things like malaria diagnosis and treatment. We're not getting all of the commodities we need to the providers that need to be able to use them, to the community health workers that are meeting with community members. So we still have a lot of room to grow and improve in our existing tools, but we've always recognized that even our existing tools, even if we got performance optimized, are not going to get us to elimination and eradication everywhere. The countries that have managed to eliminate have largely been either island countries or have had fairly well-developed economic situation. They are able to provide diagnosis and treatment to everyone who has malaria or febrile illness. And until we get to that level in many of the countries in sub-Saharan Africa, we're going to be challenged by malaria elimination. But this vaccine even if it doesn't get us, even if it isn't a transmission interrupting vaccine, even if it's a vaccine that is having impact on mortality, it doesn't diminish the promise or the impact that this vaccine is likely to have, these two vaccines. And the vaccines that are to come. We know we're learning all the time. We have incredible new technologies. You know, the COVID vaccine, mRNA vaccines are a new technology that may allow us to have vaccines that have attack multiple life stages of the vaccine instead of just one. And so there's really a huge promise now in the future with these technologies, as well as other areas such as vector control. So we're moving into another phase where we've recognized that we need to do better with what we have, but we also need to bring some new tools to bear. So I'm quite optimistic that in the future we will be able to have significant impact on malaria transmission in general and the burden of malaria more globally. So I'll just stop with that and look forward to the discussion that we have with all of the people at the table who all play like such a critical role in this global fight against malaria. Thank you.
Thank you for this positive swing into the positive side of thinking. Please, Dr. Asante.
Well, thank you very much. And I'm pleased to be here, and thanks to the organizers of Geneva Health Forum for inviting me to come all the way from Ghana to Geneva to speak on this topic. I started off working in the area of malaria as a young clinician who had just finished medical school, and I was posted to one of the quite remote areas of the country, and that was Kintampo. I got there, I had to work in the pediatric ward. I knew there was malaria. I had malaria in the past, had taken chloroquine with all its side effects, the itching and all those things. I've seen my colleagues not come to school because they had malaria. I'd also not gone to school for some times because they had malaria. I had malaria. But I didn't think malaria was that bad until I went to Kintampo. And what was the difference? The difference was that I lived in an area, an urban area. My parents were working in a university. They could identify a fever as early as I had it. In Kintampo, the people lived in rural areas. The first fever was treated with some medicine that was left behind, mostly paracetamol, which reduced the fever for them, but the malaria didn't go. They started off then with the chloroquine, and the chloroquine also didn't work. In the pediatric wards, one would typically see in the rainy season little tubes that would run from a holder to the veins of children. That was blood. That was the commonest thing you would see when you entered the pediatric ward of Kintampo. And Kintampo was similar to many other district hospitals. It was common to see children come in with convulsions, cerebral malaria, and many years after, you would see these children still having epilepsy, the long side effects of the cerebral malaria that they had had. At the time, we thought of doing something. We thought about the fact that if we were to do something about malaria, it started with us as the public health physicians, as clinicians that were seeing patients. Our colleagues, our senior colleagues, epidemiologists got together and said, we've got to do something about this. At the time, there had been the BedNet trials. There were still discussions about how to roll it out. Coverage of BedNet was about 5%, and it wasn't that high to make any significant impact then. There had to be a perfusion of BedNet and many other interventions. We were very excited to receive capacity from some of the colleagues, institutions that are represented here. RBM supported with training for research capacity. Unitaid and PATH came along supporting the vaccine trials, Unitaid for the last few sets of trials that were done. And this injection of interest and commitment to do something about the malaria parasite was impactful, and I'll tell you why. One of them is we started off trying to look for alternatives to chloroquine, which was failing. The resistance was about 50% in the area where I worked. And then we went into testing artemisinin combination therapy, which are now approved. It came with some level of clinical trial capacity. and who said at that time Africa could do clinical trials to the standard such that it would be accepted by the European Medicine Agency and it would be accepted by the African Food and Drugs Authority. But it was done with the support of various collaborators and the scientists on the African continent. We were very excited to start clinical trials for the RTS S malaria vaccine, and that was a game changer in terms of capacity development for clinical trials in general. And our institution, Kintampo Health Research Center, by virtue of where it sits within the Ghana Health Service, was chosen as one of the research centers to do this. We built capacity, trained clinicians, trained pharmacists to do these clinical trials, phase 2 clinical trials, 2 of them. First, to ensure that the vaccine was safe and it was immunogenic, and also to ensure that the vaccine could coexist with other vaccines that were given within the childhood age group. Our institution built this capacity, and now I'm happy to say that we are able to do phase 1 trials in Lassa fever. We were remodeled to do COVID vaccine trials, and then we are remodeling to do other trials in non-communicable diseases. And I'm saying this just to say that with the capacity developed, everything is possible, including malaria elimination, and also the commitment. And so, following those phase 3 trials, we were invited to put in a bid to conduct the pilot implementation studies in Ghana, and we're excited to be part of colleagues from WHO and then also from the African continent, Kenya and Malawi, to do these trials. And I'll be happy to discuss the outcome of that and the successes of this. But on the whole, I'm really excited today because we are speaking about 2 vaccines that have been approved in the last 5 years for wider use. And that, for me, is a huge leap jump forward.
Thank you so much for the story of the development of the vaccine, but also of the research center in Kintampo. Back to you, Aurelia, for some real practical side of the vaccine implementation.
Thank you, Isa, and thank you to the Geneva Health Forum for hosting us today. And it's so great to be on a panel where there is indeed so much expertise. I remember when I first started coming into questions around malaria vaccines, what's going to be the access, is there going to be enough supply, is it going to be affordable? I was meeting people and I was so impressed because all these people had dedicated their whole careers to the development of malaria vaccines, and that was in 2006. And now I can say I've devoted a chunk of my career to this question. So it has indeed been a long time in the coming. So today I'm Chief Program Officer. I look after the programmatic work at Gavi. For those of you who are less familiar with Gavi, we're a public-private partnership. We vaccinate half of the world's children against the deadliest vaccine-preventable diseases, which now includes malaria. Since the course of our existence, since 2000, we've supported over 600 vaccine introduction and campaigns. This is what we do. It's about getting vaccines out into the field. And that effectively is a whole generation of children vaccinated, 1 billion unique children. And when you vaccinate this many people and run campaigns, you save 17 lives from infectious diseases. You generate 220 billion in economic benefits. And so it's off the back of this experience that we're super excited to think now when we look at the next generation. So the generation starting from now, increasingly across the African countries that are rolling out the vaccine, will be adding the malaria vaccine into that protection. And as I mentioned, I mean, if you think back about the history, 3 decades of research, and now not just 1 but 2 vaccines. It's actually quite rare, given the time and the cost of development of a vaccine, to have at launch more than 1 vaccine. So in a way, we're in quite a privileged position, and we have a lot of supply coming online. And as was alluded to before, it's There's been some incredible research that's gone into it, and I think a lot of expertise, because here we are combining the expertise of the vaccination world with the expertise of the malaria world coming together and looking at this program together and studying RTS S extensively over a number of years, now with R21, understanding that it's a very similar mechanism, and so we can very much look at the vaccines side by side. And even in the rollouts that we've had so far, Kim quoted, I think, a very striking reduction of all-cause mortality, 13% in the pilot countries. So we've had the benefit of rolling out, of vaccinating over 2 million children in the pilot countries, so Ghana, Kenya, Malawi. This isn't something that would have never been possible by one agency alone. We partnered with UNITAID, with Global Fund. We had PATH supporting all along. We've had to have financing by organizations like MedAccess. This is a vaccine that, had it not taken a concerted effort, would have died along the way multiple times. But I think the result of when we think about 2024 this year, where countries are now rolling out in their routine programs, I think we've come a long way. In January, we had Cameroon. It was the first non-pilot country to introduce into their routine programs. We've had 8 countries in total introduced so far, probably another 7 to go this year. And our target is, by the end of next year, to have reached about 6.6 million children. And so off the back of that, I think a lot for us to think about, given the huge enthusiasm that we're seeing. We have 30 African countries who've expressed introduction for the vaccine, and obviously this is within the context of adding an intervention in their existing programs. So let me talk perhaps for a minute just about sort of what we're seeing right now on real-life implementation. We're no longer in pilot settings. It's been a long time that we're no longer in clinical trial settings. And one of the really important things now is sort of the sort of practicalities of rollout. And so for Gavi, we ask that countries really consider their data and look at their local setting. What is the transmission that we're seeing? What is the coverage and reach of existing interventions? How do we make sure that we really bring together at country level a coordination mechanism across the National Malaria Control Program, across the expanded program for immunization, so that they really work together and integrate it into the malaria programs and integrate it into the vaccine programs. And so that, for me, is really fundamental as we're moving into implementation. And then also, at global level, very much strong collaboration required, particularly, of course, with the Global Fund in terms of thinking as funding agencies, how do we best support countries? We take part in each other's mechanisms. I have what's called an independent review committee that looks at applications from countries when they want support from Gavi for the vaccines. We have folks from the Global Fund join those, and all of those, I think, are important mechanisms to bring them together, really make sure that we're supporting the country level priority and that we're very much looking at the context specifically. And, so far it's, I think, been good to see, I think, the traction on the ground. It's not without challenges. We have the benefit, Isa mentioned it in her opening remarks, of now having enough supply. For a long time, that was not the case. We had a very small amount of doses that needed to be carefully allocated. But I think it's important to keep growing the supply base, and that comes with 2 vaccines as of today, but I think really important, particularly given the specifics of malaria, that we look at production on the African continent of the malaria vaccine. We have an initiative called the African Vaccine Manufacturer Accelerator that helps support that with $1 billion fund dedicated to vaccine manufacturing on the continent, so that over time we're not held to one specific vaccine. And I think, as was alluded by my colleagues, we also look at how can we improve the vaccines over time in terms of numbers of doses, in terms of ages, efficacy, role in blocking transmission, all of those things. And then maybe just a last thought, because I think the financing aspect is really important. And for Gavi, we place a huge amount of emphasis on country ownership of their programs, and part of that ownership of programs also comes through domestic financing. And so we have what's called a co-financing mechanisms, where according to the level of wealth of a country, countries pay either a fairly symbolic amount if they're at the very low end of the spectrum, or an increasingly sort of a higher amount. And that really helps make sure that the country has skin in the game, if you like, and also increasingly over time, sustainability of the programs, and making sure that we're not just introducing a vaccine for now, but that it's going to be able to have a role in the malaria control program over time. And so that's part of the work that we do. And then also recognizing, as we're in the early stages of rollout, we're going to keep doing what we've done for a lot of the other vaccines, and doing market shaping, where working with the manufacturers, bringing the price down over time. If you take a basket of the 11, if you like, key antigens that a child needs to have, the Gavi-supported countries, the total cost is $28. So, which is shared between the country and Gavi. That compares to an equivalent cost of $1,300 in high-income countries. Take the US, for example. And so, of course, here for malaria, there's no dual market. We're really talking about particularly the African continent here. But I think that notion of affordability, and increasing the affordability and the diversity of supply over time will be critical. So thank you very much, and let me pause here.
Thank you so much, Aurelia. It's super interesting to know where we are. And I think really nice to give the word now to Michael from PATH Malaria to bring this perspective of needing to work together.
Great, thank you. Thank you very much, and thanks again to the Geneva Health Forum for inviting me. My name's Michael Charles, RBM Partnership CEO. Allow me to tell you my story and my journey around malaria. As a medical doctor working in one of the most densely populated cities in Africa or in the world, in Lagos, I was acquainted one night with the patients that came in. It was a mother holding a baby of 9 months old. His name was Sule. Sule came in, he was convulsing, he was febrile, and luckily we were able to treat Sule. After 3-4 days of being on the ward, Sule went home hale and hearty. Unfortunately, 6 months later, Sule came back to the ward. He was dehydrated, malnourished, febrile, convulsing, and Sule passed away. This was in 1997. That was the time when a child died every 30 seconds. And the world came together and said, never again should we allow this. And it was around that time that, Rollback Malaria was formed, which is really a partnership to bring all the malaria stakeholders together, in a common approach in terms of what do we do. Years later, a few years later, Global Fund was formed. And together, collectively, together with WHO and many of the stakeholders, we said never again. Unfortunately, 25 years down the line, we're still repeating never again, never again, never again. Although we're still seeing that a child dies every minute of malaria. So from the RBM partnership perspective, our role is really to coordinate the various partners around malaria. We have convening spaces where we bring partners together to talk about common issues, and where we try to communicate, advocate in terms of keeping malaria high on the political agenda. We welcome very much the vaccines, the 2 vaccines that have been introduced. This, we feel, is definitely one of the tools in the toolbox, one of the many tools. Incidentally, this morning before I came here, I was with the First Lady of Malawi, one of the pilot countries. And we were talking about her contribution and her focus on malaria and gender. And she asked me a question. Now that we have the malaria vaccine, now that we're rolling it out in many countries, can we say that elimination is near? And I said, well, we can't say that, although she was disappointed with my answer. But I said we can't say that because the vaccines alone is not going to do it. We need to continue to use existing tools. We need to make sure that bed nets are being used, SMCs being administered together with the vaccines. So vaccines alone is not a silver bullet, but it's certainly a step in the right direction, and we welcome the innovation. I hear my colleagues talk about market shaping. Exactly that's what we want. We want to try to bring the price down as much as possible. But countries face a difficult choice. In the advent of limited funding, we have vaccines, we have bed nets, we have prophylaxis, prevention. What should countries do? And that's why we're working closely with WHO in terms of the subnational tailoring where, based on the data, based on the evidence that we have, not one size fits all. So how do we prioritize based on the epidemiology and the data and the surveillance that we're seeing? So that's very much welcomed from our perspectives. Some of the challenges we're also seeing on the country level, as Philip said, when we were in Cameroon together in March, where we actually witnessed the vaccination taking place. I think part of the challenge we're seeing from a country perspective is the challenges between the malaria program as well as the expanded program on immunization. Sometimes at country level, they don't talk to each other. So really bringing them together towards a common objective, I think it's quite important. As some of my colleagues have said, financing is also an issue. So again, working through with countries in terms of how do they finance this on the longer term, I think it's something that we're working on as well. I commend Gavi in terms of the Africa Vaccine Manufacturing Accelerator scheme. I think that's also something good and something we're hearing from Africa CDC and from our other colleagues in terms of how do we ensure that some of these innovations, some of these vaccines are able to be produced on the African continent. I think finally for me it is really looking into our African researchers, into the academia. How do we continue to strengthen them? How do we continue to support in terms of the rollout of this? I think eliminating malaria is definitely possible, but we cannot do it from a health perspective alone. If we look at the other countries that have been able to eliminate malaria, we've seen that development has been an integral part of it and a multi-sectorial approach. So from the RBM partnership perspective, what we're calling for is obviously development, obviously using malaria as an accelerator towards development, but also ensuring that innovation is really part of our day-to-day business. So really welcome the vaccines and really looking forward to its rollout in many of the countries and working together with the colleagues around the panel here as well in terms of just making sure that prioritization, subnational tailoring is done and we can bring the best to the population so that in a few years' time we can truly say never again. Thank you.
Thank you so much. Thank you so much for these interesting insights. Before we open the floor to the public for the questions, I just wanted us to discuss a little bit more on the challenges as well. I think maybe it wasn't, we alluded several times that this is a complicated vaccine when it comes to the implementation. It comes in 4 doses. And the first 3 doses have to be delivered in monthly intervals, but in a different time frame than the other routine vaccines, right? So it starts from the month 5 on. So this means additional 3 visits to the health facilities to get these vaccines. It was mentioned before we need to bring the different malaria interventions together, and there are other programs that are implemented like SMC that was discussed previously. But the vaccine doesn't necessarily, there's been studies showing that the vaccine works much better when it's combined, but in reality we are not rolling out in this way. So I wanted all of you mentioned resources, and there are limited resources. And I think the resources are actually not just the money, it's also how actually we put that in place with the addition. It's even a resource for the mother that now has to come 4 times more to the health facilities. So how do we bring that together? And I wanted to ask some of these more maybe technical questions around the combination of the different interventions, the results of the studies, maybe if you could mention those. And then in practice, how can we bridge the 2 programs that are used to work independently? They have different funding mechanisms. So how we can bring them to work together and to be accountable together. So I don't know, maybe I can start with Dr. Asante, and then we'll just do the round.
Well, thank you very much. So some of the pilot implementation results have been mentioned across, but just to highlight that this was a very large study, very interesting study, and to see that a vaccine that had been introduced over 4 years, the coverage of dose 1 was about 75% for the first RTS S dose that was given, say, in Ghana, 69% in Kenya, and 63% in Malawi. This is for the first dose, which was slightly higher in other micro places within these countries. It also led to about 30% reduction in severe malaria hospitalization after 24 months, reduced to about 22% after 46 months. And then the exciting bit is that it's reduced mortality, all-cause mortality, by about 13%. And if we note the total number of mortality among young children in these areas, to reduce by 13% is a significant amount. In terms of what next in terms of combining and then working with different departments of the health service, I think it's a lot of engagement between these two departments, let's say. And it's also got to do a lot with the funding mechanism. Who funds vaccines and who funds malaria? You know, different people are funding it and they are talking to different people, and sometimes there's also territorialism, and all these things would have to be discussed quite openly among funders, among the implementers and policymakers, such that at the end of the day, we have the child in focus, and then we have the health worker in focus. At the end of the day, we want to see survival at that ecosystem in that small village in Kintampo. They don't know malaria program, neither do they know EPI program. What they know is vaccines are there, we'll give it. The drugs are there, we'll give it to the child. And let me extend it and make it even more complex. For the mothers, we are talking about the reproductive health program. And so these are 3 different groups, but it's the mother and the child we are speaking to. So we just need to coordinate that and ensure that this works well. And that would also happen very well if the ownership of the whole system is managed at the micro level, right? I was very excited to see in one of the meetings I attended for the malaria program that was doing the subnational stratification to ensure that the interventions are targeted to people that need it most. There were people working within the health service that sat from 8 a.m. to about 8 p.m. thinking and mining their own data to decide where to put which intervention, irrespective of which program it was coming from. And I was very excited to see that, and I thought that is what should be continued. That level of ownership, and I'm again excited about the initiative of Zero Malaria Starts With Me. This is catching on. I see many countries have started. I see the fact that we are now considering malaria as a multi-sectorial issue. We are seeing musicians, we are seeing environmentalists, many people in that space And I feel that that is very important. We are currently conducting a study that is seeking to combine SMC with, or PMC, which is perennial malaria chemoprevention. That means in places where there is malaria throughout the whole year, can we add drugs to prevent malaria, and also can we add the malaria vaccine? That is still ongoing, but I can say that acceptability is quite high. We are hoping to see reductions in clinical malaria, as we saw for SMC, which was about 62% for clinical malaria, and about 70% for hospital admissions, in studies that were done by the London School and also their partners in Burkina Faso and Mali. These are very exciting, and I think that if these collaborations and then the ownership is enhanced, we'll be able to make a headway towards malaria elimination.
Thank you. Do you want to continue?
Yeah, I maybe wanted to pick up on something that KP and Michael also spoke on, and something that's perhaps facilitated more of the coordination between EPI and malaria now that we have the vaccine, which is actually a sea change in the way we've approached malaria. When the Global Malaria Eradication Program started in 1955, it was very much, we're going to do IRS, and that was pretty much the extent of the interventions and program, and we're going to do it everywhere. And I think that was clearly not the right approach, and there's been increasing, well, there's always been a recognition, but maybe increasing using this recognition that malaria is a different epidemiology in different places. And we need to make sure that the interventions we're putting in are suitable, and we need to have local decision-making around what those interventions should be. So it was about 6 or 7 years ago that WHO began to back off its very prescriptive recommendations and said give more general guidelines and say, this is what we know, this is the extent of what we know, here's what we don't know, and here's what countries can do to use their own data and make their own decisions about what interventions should be applied in different parts of the country. The subnational tailoring approach is a way to make that a process that engages multiple stakeholders in different sectors and uses the best data available to decide what interventions need to go in what places. And it's now facilitating this really very specific discussion about where should the vaccine go. WHO now says it can be used from low to high areas, but that doesn't mean it's the best allocation of the vaccine. And so we have this process now that countries are using where their best malaria scientists, their best public health scientists are coming together and figuring out what's the appropriate kind of mix of interventions in different areas. And this is really remarkable. It's really a revolution in the way that countries are approaching malaria prevention, control, and elimination, and it's quite exciting, and I think it's laid the base, the foundation now, to be able to have a very productive collaboration between the EPI program and the malaria program and the reproductive health program and the child health programs in a way that we didn't really have before.
Thank you. I would just like to continue with the same question to the more on the donor side. Like, as you mentioned, I think a lot of it, I mean, how can donors help that there is not a separation of, the funding for particular intervention? Because the countries are then also supposed to report based on this particular intervention, and it's for them as well difficult to mix the resources for multi-interventions.
Yeah, I mean, it was said before, the free reality for countries is then first the funding they can receive, the funding they have, and make choices. That's the hard one. I think that in public health, generally speaking, we are doing 3 mistakes. The first one is not to pay sufficient attention to innovation. And in fact, we need to figure out the innovation because it brings solution, not just because of the product, but how it is used, including by the people themselves, by the health workers, by the community, and in particular in malaria, we can see the benefit and the resilience of community-based intervention. Frankly, it's very powerful. And the last thing is that it's historical, but people in public health generally think that poor people cannot, in fact, use the innovation, which is also totally wrong. What I'm trying to say is, yes, the finance, but there are also the people. Before the complication of funding, I mean, to be a mother cannot, it's already a full-time job. But to go to the clinic every day, that's not possible. People need to live their life, they need to work, they need to take care of the baby. So it's a difficult question. It's also for the health worker system, the minister. And I think that, to be honest, I think we need to be a little bit more creative on that, because we still have a lot of operation in silos. It's really clear every time you go to all the country, you know, and I think that's an issue. And then the technical decision. Look, it's the story of Mohamed PATH. We need to be serious about how we measure the performance, but both ways. So to be comprehensive, not also to overburden the countries. I think that, to be honest, there is an issue also there. Let's be honest. All our donors wants to have all the report on everything and make sure that, of course, the money is used well. This is what to do. We do. But there are limits. There are limits, but there are also capacities. So I think that in the technology, we can also find a way to simplify a lot of things that has implication in overall, for example, epidemiological surveillance, the management. So there is also a knee health that has to be managed, by the way, but can also simplify. But the e-health has to be managed by human brains to take into consideration the needs of the people as the first thing to do.
Thank you. Did you want to react?
Yeah. Maybe just to add to the discussion and to pick up from what Philip said. I think a lot of the challenges is also caused by some of the global institutions. You know, what do I mean by that? If we're saying, you know, countries are not meeting their malaria targets, but I take the last 2 months, for example, I went to a particular country 1 week to meet with the minister. Another global health institution goes to the same country to meet with the minister. In the space of 5 weeks, there were 5 different heads of agencies. And we complain that the work is not done. So how do we bring that together to ensure that, you know, we coordinate a little bit better? You know, when we're talking about the tensions between expanded program on immunization and the malaria program, all fits within the Ministry of Health. So what we're trying to do now is to ensure that, you know, through the minister and the ministry, that there's really alignment. And not because I'm Nigerian and not because Philip has mentioned Dr. PATH many times, but Dr. PATH has really tried to do this when he brought all the stakeholders together and said, let us rethink malaria, but within a sector-wide approach. So not looking at it holistically as one silo, but how do we look at it within the environment of everything else that is happening? And I think that's the way we need to go. We need to continue to encourage our ministers to be able to take bold steps, which takes me to the last point to say, within, you know, the global health institutions, there's also what we call the Lusaka agenda, which is an agenda that people are now talking about in terms of how do we have one reporting, one budget, you know, one plan. And I think, you know, as we move along, that's ideally where we want to get to, but how do we get there in practice? I think it's still going to take a lot of effort, but at the end of the day, we need to make sure that we simplify things for countries rather than making it complicated, and then we have so many demands on the countries, and as partners, where we'll be the first people to complain, to say the country is not doing this, the country is not doing that. So I think we also need to look at ourselves to see how we can support countries better. Thank you.
Thank you. Please, sir.
I just wanted to bounce back with a few thoughts. And I mean, I think certainly the global health architecture is a pretty complicated space. But as a couple of folks have been saying, I think we really need to take it back to the country level. And I hear a lot of the issues and concerns around, is there going to be enough money? This isn't a vaccine like measles that's almost 100% efficacious, at least these two initial ones. The delivery is very complicated. I think all of those things are very, very true, but I think we also need to take the glass half full perspective in terms of, I mean, this is a disease that's real and present danger. You go to Africa, you've either had it yourself or you're related to someone who's had it multiple times. In Burkina, 30% of hospitalizations are malaria related. So you have not only the attention of the Minister of Health, you have the attention of the Minister of Finance because of the economic burden and cost that this is driving. And I think this is a huge opportunity, I think, to think about how we adapt our programs. Isa, you mentioned the 4 doses. The initial countries that are rolling out at the moment are looking at their schedules and thinking, hang on a minute, if I put my 4th dose at the same time as my 2nd dose of measles, that's going to give me better coverage on both. And it takes one visit out for very busy caregivers. I was in Ghana in December, and when the last vaccination is done, the vaccination record is completed, and it's given alongside a bed net. And there's a session dedicated for, it only lasts a minute or so, to talk about malaria prevention for the child, which now will no longer be coming in, but having had its last dose of vaccine on malaria prevention specifically. And we've seen a lot we've run a couple of workshops already for countries who have introduced with a view to bringing countries who are about to introduce to talk about some of what's worked for them and what hasn't worked for them. And I think those are extremely fertile places. They do give us feedback in terms of, how many application forms do we need to fill in and whatnot. And I think those are all well noted for us to take back. But they also, I think, are a huge ground of innovation in terms of how we deliver. And I think sometimes we can be, as health agencies, a little patronizing because what we're hearing from countries is, well, actually, there's so much enthusiasm around the malaria vaccine rollout. That's good for non-vaccine interventions because it revitalizes the malaria program. And in certain instances, it's benefiting the vaccine programs for other diseases because there's so much political visibility on it that now coverage rates of other vaccines are under question because you need to be able to introduce a vaccine in areas where the coverage rates is enough to be able to deliver what is currently a 4-dose schedule. And so I think those are all opportunities that I think are behooving us, and I think to listen and see where we can evolve, and I think it will benefit much more broadly than just the malaria vaccine rollout.
Thank you, and thanks for bringing up the opportunities as well. And I think the new WHO recommendations, they do recommend the co-administration of other vaccines. And then I think it's also opportunity for catch-up vaccinations, as you mentioned. Before I open the floor, I just wanted to ask each of you, do you think the malaria vaccine is a game changer in malaria control? Yes or no, or maybe? Very briefly, please, so that we can have some time for discussion.
It's a game changer, but subject to confirmation and potentially new vaccines that are in the pipe.
Thank you.
Potentially for mortality from malaria, yes.
It's a game changer. Lots to be done. New vaccines, transmission blocking ones.
It's a new up-and-coming talent in a talented football team. It will eventually get to World Cup.
I think I'm of the same view as well. It's in the process of being a game changer. Watch the space. With more innovation, we'll get there.
Thank you. That was a fantastic. So I would like, thank you so much. And we'll open the floor for questions. If I don't see anything. Yeah, there is a question.
Hi, can you hear me? Hi, I'm Marianne McCabe from GSK. We're really thrilled that we're having this session today, of course. The malaria vaccine has been a very long journey for us and has involved many, many stakeholders. And so we're thrilled that after 35 years or more of innovation and coming to market, Gavi-funded doses are being rolled out as we speak. There's been some questions about supply and price of the RTS S vaccine, and I just wanted to answer any questions around that. I wanted to reassure you that, of course, first mover innovators are always come to market more expensive. We've seen that with many other vaccines, but as manufacturing scales up and new manufacturers come in, volumes increase and price comes down. We at GSK are certainly looking into our manufacturing and trying to squeeze out as much additional supply as possible. And of course, we're accelerating our tech transfer to Bharat and doing all that we can to make that go faster so additional lower cost vaccines come online as quickly as possible. I also wanted to highlight we're also working on a second generation malaria vaccines. We're very committed to continuing to innovate and being part of this coalition of partners going forward. I do think, as you've heard, it takes a whole community of different kinds of stakeholders, from R&D to access at scale to experts at the country level and implementation, demand generation, et cetera. I think we've learned a lot as a company and as stakeholders. We've heard about programmatic innovation. We as GSK and the private sector would be very happy and willing to be engaged in future conversations and panels such as this one to share our perspectives, not only on malaria interventions and malaria vaccines, but also looking ahead to other complex introductions of innovations like TB vaccines, et cetera. So I wanted to just reassure you of our ongoing commitment both on innovation and supply in the malaria space. Thanks.
Thank you. Thank you. Any other question? Yes, here in the front and there in the middle. There. Here and there. There is another question after there, behind you.
Hello, my name is Patience Akumu. I'm from RBM Partnership to End Malaria. So I'm just listening. I'm 3 weeks old in my role, and I'm asking myself, where was the vaccine party? Where was the Trans Day celebration of this vaccine, this beautiful innovation? Of course, we knew that two vaccines were discovered, but we did not see the pomp that should have surrounded it. And that brings me to my question. In a world where people are investing a lot of time in misinformation, whether we want it or not, they're talking about these things. They're religious people. They're radicals of different types. They're on TikTok. They're everywhere. And they're spending time campaigning vaccines, including the malaria vaccine. So what are we doing to counter this information? And maybe this will go to Sanya in particular, because I look at your website, you talk about the beautiful experiences on vaccines in Malawi. You spoke about that individual child whose life was saved, not just a random child, not just a group of children, but bringing it down to the person. You have all these beautiful statistics, this beautiful research, this beautiful information, but people are investing in misinformation. How do we collaborate to counter and strongly, strongly counter the misinformation? Because a lot is being invested in that. Thank you.
Thank you.
So I think by Sanya you meant maybe Aurelia. This was the question was directed at me. Okay. So you're absolutely right, and we live in an era, we saw this with COVID-19, vaccines, where we really saw social media play a really important role, both positive and unfortunately negative, in terms of misinformation around vaccines. And of course, this is a very high-profile vaccine off the back of the COVID-19 use. And I think first and foremost, how I consider it is to think about the fact that it's very context-specific. And it needs to be treated as such. So it's very different whether you have a community that refuses to use government facilities because of mistrust of a government versus having information about a particular vaccine being perhaps not safe and efficacious, which is circulating on TikTok or Insta or other platforms. And so we actually have dedicated financial support to communication, and whether it be working with social media, but also working very much at community level, making sure that we understand who are the trusted sources of advice in the community and engaging them. And here, I mean, I think, I'll give a particular plug, for example, to youth networks and, the ability to really be able to have information provided in a way that's approachable. The questions people ask about vaccines are completely legitimate. It's whether they have information that's accessible and correct, I think, is an important part. I actually had, for the launch in Burkina Faso and Cameroon, I had my goddaughter, who's 14-year-old, help produce TikTok posts to explain and do it in a way that was very much sort of, being able to do peer-to-peer communication. It is something I think that is not unique to malaria vaccines, but I think it's in a context where it's highly visible, and we need to keep working on it very, very much within the specific issues and concerns that are arising.
So I'll just give the Dr. Asante.
Well, thank you very much. I think that's a good point, and I would say that malaria vaccine really enjoyed because the misinformation was not as much as COVID-19 vaccines, and I've been involved in both vaccines. And in my country and other countries, people have been trained, like the trusted people you spoke about. They've been trained to sort of give the right information and to answer questions appropriately. I think one of the things is we don't usually give the right information to people in the right context. And so sometimes when others come in with misinformation, then they get carried away. But once we have focal persons who are trained to speak in, say, local language, how do you explain efficacy in local language? It's difficult. So people have been taught to do that. And all those measures have helped with the malaria vaccine and also helped with COVID vaccine, for instance.
Yeah, maybe just to add to that as well is, again, what we try to promote with countries is what we call community engagement and accountability, really making sure that we engage the communities, understand, the issues, understand the challenges, and then try to address it then and there. And this brings me to the point of what the Africa CDC is trying to do in terms of making sure that there are 2 million community health workers on the African continent that can be close to the communities and able to address not only issues around hesitancy, but issues around health in total. So I think, by and large, community engagement and accountability, and then working with CSOs just to make sure that, we have a robust system and a feedback mechanism.
And the last word to Philippe on the topic, and then we move to the next question. Maybe.
Yeah, well, I think it's a common concern in interest, I think. We have experienced partnership with MTV Foundation, for example, for launching the self-test in Africa. And we plugged information in the series on internet, Sugar Daddy, and was really made, well, we provided the basic information, but it was made with, of course, actors from Africa, by director in Africa for Africans. And to be honest, I was in a school for health workers, young health workers, to see some of this. They were laughing all the time. I didn't understand half of it. But I think it's very powerful. And I think that in the work that we are doing, we need to use more and more, because even the World Bank have assessed that kind of intervention. And in fact, there is a huge return in investment. So we need to also be realistic, because there are malicious intention, sometimes from states. I will not name them, but we can think about some of them. But it should be part of the plan, I think, more and more. It's something that, with the government, of course, we need to do that.
Yeah.
Yes.
Thank you very much. We had a question there. Yes, please.
Hello. Hello.
Yeah, it's okay. You can.
Thank you. My name is Andrés de Francisco. I'm the president of a new founded society here in Switzerland, ERAS Development Group. Thank you very much for the presentations. I have to say I missed part of it, and you might have answered this question already. Just thinking about the current pattern of malaria and also the climate change that is basically taking us over, and the effect that it's having on malaria, but also on dengue. Dengue fever right now is increasingly expected. If there was a situation in which there will be an epidemic, which might as well, in the northern countries, from one day to the other, or pretty soon, will this vaccine be possible to crank up production of this vaccine so as to have it both in the north or in the south? I'm referring to our situation that happened with the COVID vaccines and so on. So will that be, are we prepared to do this, or we will think about it later? Thank you.
Can I just ask a sub-question to your question before you start answering? I think that's a very interesting question, and I was thinking before about the vaccine, and I have today the vaccine is really used for young children to prevent mortality as much as possible. But do we know, I mean, what would happen if we give vaccine to an adult? Would it still prevent morbidity in the same way or not? It was said several times today that the vaccine doesn't prevent transmission, but I think that's maybe not absolutely true. Maybe it's just not the main objective. So, like, would it be actually helpful as an outbreak intervention? And then the other, I think the use that we, as MSF, we sometimes encounter in places where there is a massive displacement of population in areas with a different malaria epidemiology. And we use other API vaccines to rapidly decrease the burden of vaccine-preventable diseases. Could we consider malaria vaccine to be one of the vaccines in this package? So maybe I start with you.
I will let my colleagues respond specifically on malaria. I think that the scenario described by malaria is so far not likely to happen soon. But for dengue, it's already there. I was in Brazil a couple of months ago. They have a massive outbreak of dengue. And by the way, they have started to use the vaccination for the first time at high scale. And to be honest, the mosquito for dengue are here in Switzerland. Last year, there was autochthon cases in France, Italy, and that's for sure the climate change will have an impact on dengue. That's, by the way, why we develop, it's already active in the south. So, yeah, it will come in the north. And it's a reason why also, by the way, we develop a special repellent that can work to block the mosquito from malaria, but also dengue. What colleagues?
Yeah, I agree. I don't think that's a scenario that's very likely for many reasons, in particular just because the housing situation and the level of development is so much higher in Europe. I mean, there's certainly some interest in trying this current vaccine in older ages, but I don't think this is the vaccine that people think will be appropriate for older ages. There are new vaccines coming in that are going to target other life stages. that may be more applicable for the older ages, and maybe they will show an impact and perhaps could be used in outbreak situations, but I think we're still needing to focus this vaccine on where the true burden is, which is deaths in African children.
I can answer the easy bit of the question in terms of giving you some numbers on supply. We estimate we'll have somewhere along the lines of 40 to 60 million doses available by 2026, and that's going to increase to 80 to 100 million by 2030. So this is one where for a long time supply was an issue. I think now not so much. I think the broader point here is it's really important when we think about vaccine innovation, there's also the manufacturing side of things, and this is something that the pharmaceutical industry has been grappling with for a very long time, which is given the very high fixed costs, because very often a manufacturing plant will only be able to do one vaccine or maybe two, but because of the technology, the economies of scale needed, etc., it's not easy to deploy from one vaccine to the other the next day. And we saw in COVID-19, it took a while to ramp up facilities to the scale needed. And so I think that's a broader plan of work that is very important, just in terms of how do we think about the technologies that are used and how do we think about the footprint so that we can have flexibility, because we may have surprises along, or I should say we will have surprises along the way when it comes to infectious diseases and pathogens, and vaccines is an important part of the response.
Thank you. Any other question from the public? Yes, they're here in front.
Thank you very much for all the information. Again, I'm Francesca. I have introduced myself several times. Do you know, in the treatment of malaria, sometimes we have such discomforting side effects. So I wish to ask, is there any collection of data about how the treatment of malaria impacts on people? And has there been anything done to modify, the process of treatment, so as to make it, I don't know whether to say friendly, because if you are sick, there's nothing friendly about it. But has there been some way of trying to modify the strength of the treatment, so that people don't have to suffer so much?
It's a hard question for our panel on the vaccines, but I think vaccine is a solution, probably. Do you want to?
Well, in terms of monitoring of adverse events, as they call it, the countries do have post-marketing surveillance for adverse events. So if a child falls ill or has some specific symptoms after taking the medication, they do report. But that system sometimes is a bit weak and may not be able to collect all that information that we are interested in. I know some sponsors also specifically do what they call a cohort event monitoring to identify some of these rare adverse events. So there are systems in place for that.
Thank you so much. Maybe I'll just, if there is no urgent questions, I think we'll just, there is, okay, the last one then before the break.
Thank you. Thank you. Basi Akawa is my name, once again, a parliamentarian with Nigerian Parliament. A rider to the question that has to do with the mist of information on the social media space. I think this is a platform that I need to get this again clear, because there's been these information about those people that actually took the COVID-19 vaccine. They turned them to an animal. So if it's true, or if it is a misinformation on the public space, then what are we doing? Because because if we allowed it to, continue this kind of information to continue, to even take the malaria vaccine will also be a problem to some locals, with this. I don't know what strategy that we are using to actually get this, corrected so that people could, get this on. Thank you.
I think we had quite a long discussion on the same question just before, but I don't know if someone has, if anyone wants to react.
Well, I was very excited to hear you introduce yourself as a parliamentarian in the previous session and now. And that tells me the interest, and this is the way to go. Parliamentarians do have a strong voice in the communities. And so if we have parliamentarians that stand up and stand for curbing miscommunication, that would be one of the ways forward. And I think that this is one of the things that parliamentarians or political leaders at the community level and also at the national level should take charge of and then also take it forward. Not for it to become a political issue.
Couldn't have said it better.
Yeah. Thank you. Is there any final remarks would you like to make any final remarks on your side? Any message we didn't pass and we really wanted to pass to the public? If not, then I really, really thank you very much. I thank you all for listening. I think we can conclude that the malaria vaccine is a game changer, but in waiting, so we still have to see what will happen. But it's another tool in the toolbox of the tools we have to control the malaria. It comes with challenges, but it also comes with a lot of opportunities to also revitalize other tools that we have been using so far, but maybe not good enough. So thank you very much. And,
thank you.
Thank you.